Hello, everyone, and welcome. My name is Kara Cook. I'm the Climate and Health Program Manager for the Alliance of Nurses for Healthy Environments. Thank you for joining today's webinar titled Environmental Nutrition in the Food as Medicine Movement. The webinar today will focus on the benefits of organically grown food for patients, communities, and the environment, as well as address the state of the field regarding integration of food as a covered medical benefit. Before we get started, I just have a few housekeeping items. We'll take questions at the end of the presentation. You can enter a question at any time during or after the presentation by entering it into the chat box in the bottom left-hand corner of the screen. This webinar is being recorded, and the link will be sent out to those who registered for the webinar. We will also be offering one nursing CE for viewing the webinar. A link to complete an evaluation will be sent out by email within the next couple days. And just remember, you must complete the evaluation to receive continuing education. With that, I'm going to turn it over to Dr. Barbara Sattler, ANHE board member, professor at the University of San Francisco, and an international leader in environmental health and nursing to get us started.
Hi, and thank you, Kara. And I'm delighted to see so many people having joined us on this call. I've been working with Megan Edelman over the last year to help organize a whole range of webinars. Many of you have been on some or even all of them. And last month, we had the first gathering on a Monday that was actually a committee meeting of people so that we could talk to each other. And what we decided was to identify what all of our collective interests were. And so I'm going to summarize those here. And we also decided that what we're going to start doing now is every other month, we'll be having an informational webinar. And then on the intervening month, we'll have a call so we can begin to think about how we can take action and begin to move on some of these incredibly important issues associated with food and agriculture. So these are a list. They are not per se a list in priority order, but the ones that are listed in green, those came up several times by you when we were talking about your interests, and I'll talk about the blue ones in a second. So people were concerned about the quality of our school lunches. Very concerned about the relationship between the food that we're eating and chronic diseases, including cancer, but also obesity. And several people mentioned also mental health issues. There were several folks who were concerned about pesticide use, nutrient density, and the nutritional status of our foods was of interest. And from a variety of perspectives, food security was of issue. And separately, though addressing that to a small extent, our community supported a community sustainable agriculture. And then a number of people were interested in food as medicine. And we're delighted that Cathryn is going to be speaking about that in just a few minutes. There was also concern overall about how food and agriculture fits into climate change, what the total carbon footprint of food and farming is, and also in looking at, a couple of folks were interested in regenerative agriculture and ways in which we can use different processes so that we can actually sequester carbon. Then folks were interested in how do we move more towards plant-based diet, soil health and water, and food waste. And the two that are in blue, plant-based diets and food waste, are part of a new program that is going to be launched by the Alliance of Nurses for Healthy Environments in April, called the Nurses Drawdown Project. And these two issues, plant-based diet and food waste, will be part of this new project. And all of you who are on the ANHE listserv will be getting information about that. In addition, people talked about, well, how should we begin to work on some of these issues. And these were some of the suggestions that we enhance and develop curriculum materials and educational efforts, that we work with our existing nursing organizations, and that we be part of the changing of the narrative about what it means to have healthy food and access to healthy food. And finally, many were interested in food and agricultural policies and how we might work within our nursing organizations to advocate for some. There was one of the people that was on the call, or perhaps two or three, mentioned that several nursing organizations have policies on food and agriculture. But then the question is, how do we amplify them and how do we develop associated actions? So this is just a brief summary of the last call, and we will be having a call again on the first Monday of April, and I'll mention that again at the end. But now I'd like to introduce our speaker for today, Cathryn Couch, who I consider a friend and a colleague, who is out in California. She's the executive director of the Ceres project, which is quite an amazing project that it's this combination, and you'll hear about it, of youth and a community engagement and getting food to some of our most vulnerable populations at a time when one of the members of a household has a serious health challenge. And she sort of wandered into this a little bit, was always interested in cooking and working around food, and became interested in this in an evolutionary way, which I know she'll speak about. But her project started small and a community level, and what she then began to realize is that to really have an impact, you need to begin to elevate some of your work. And she has now become a policy champion in California and in the country around the food and nutrition and food access issues that she's been on the ground working on for many years. And she is just a huge hero of mine. And so we're very pleased to have her, and welcome, Cathryn.
Thank you so much, Barb. And thank you everyone for having me. I'm really excited to be talking with all of you around the country about some issues that I'm really deeply passionate about. So just to give you a quick overview, I'm going to talk about Ceres Community Project, the nonprofit that I run here in Northern California, and give you kind of an overview of our model, which is a layered model that includes many kind of opportunities for impact at the community level. And then I'm going to switch gears and talk a little bit about food as medicine nationally, and a little bit of a state of the field report on some of the really exciting things that are happening in that space. And I'll touch a little bit on organic as well. So to start, as Barb said, I started Ceres Community Project about 13 years ago this month, after someone had asked me if I would teach her daughter how to cook and hire her daughter, and I didn't have a way to do that. And I quickly recognized that there were families in our community that were going through health crises that could really use food support. And so in the summer of 2006, for 7 weeks, I created a one afternoon a week project where a teenager and I taught a teenager how to cook, and we supported 3 families, all of whom were going through a health crisis. One of them was a family here in Sebastopol where the mom had stage 4 metastasized breast cancer and a couple preteens, another older woman going through breast cancer by herself, and a man who'd had a stroke. And I quickly realized as we were doing this that there were so many more people that could benefit, and that I had the opportunity to connect 2 things that I felt were really critical for the health of our community. The first one was to bring teenagers into the kitchen and teach them how to cook healthy food, because I believe that that's an essential life skill for the health of this generation and for every generation coming after. And by teaching them how to cook, the side benefit of that would be that meals would go to families in our community that were struggling with a health crisis. And one of the things that we know is that when people get sick, they most need to eat well. And for a whole host of reasons, preparing healthy food often goes to the bottom of the list. And so that was really the start for Ceres. Our mission statement is we create health for people, communities, and the planet through love, healing food, and empowering the next generation. We know that social connections are also critically important for health outcomes. And in many ways, you'll see as I go forward that Ceres is in some ways a structure of support for reconnecting all of us across the community in ways that are really meaningful and that build our health and well-being. So I always show this slide. I am in a kind of a unique situation. I work on both sides of this circle, and I'll just say briefly, in my food as medicine work with medically tailored meal providers across the country and in the healthcare sector, the three things on the left side of the circle, food insecurity, social disconnection, and chronic disease, are kind of where the conversation is. We also work with California certified organic farmers and many organic companies and many people in the food and ag space. And those people tend to be on the right side of the circle: climate change, environmental degradation, unsustainable and unhealthy food systems. But as all of you know, this is one circle and it's one system. And a lot of our work and a lot of my work in the space right now is connecting people across the two sides of this circle and getting them to understand a fuller picture of this circle and helping them become advocates for the whole circle, no matter what table they're sitting at. So I'm going to just mention Healthcare Without Harm's environmental nutrition framework. I think this is really, really critically important. We are an environmental nutrition organization. And what this means is that you have to look beyond just the nutrients in food when you're thinking about health, because the truth is all of us are healthy within a family, within a community, within a food system, within an environment, within a climate. And this is a really critical shift that we all need to make. And when I'm doing work at the community level and at the state level around food quality guidelines, for example, I often share the environmental nutrition framework that Healthcare Without Harm developed. So I think all of these are ideas that you guys are comfortable with and familiar with. So here's the way we think about the work that we do at Ceres now. And as Barb mentioned, Ceres started as a one-day-a-week volunteer project in a church in Sebastopol, California. Myself and 6 teenagers cooking meals for 4 families. We're now 34 staff and almost a $3 million budget and very, very active in the policy space. But we still our core work is still at the community level. So we're about nourishing people, putting whole organic food at the center of health and well-being. That's part of everything we do. We do a lot of educational work, as you'll see. We are the only 100% organic medically tailored meal provider in the country. And we really talk a lot about, and we also think of nourishment in terms of how we connect people, which is the second piece of our work. So we bring people together to experience their belonging and deepen their capacity for compassion and generosity. And there's a really terrific study around social connections. Basically, what it says is that when we're connected in meaningful ways with one another, and this is our own felt experience, we are 50% more likely to be alive an average of 8 years later. And if we do not feel connected, if we feel alone and disconnected, it's as bad for our health as being obese or smoking 15 cigarettes a day. And I think this is something that we need to talk a lot more about in our work around health. We need to feel like we matter in our world, and we need to feel like there's a place for us. So that's a really critical part of our work. And you'll see as we get into the model, we engage about 1,000 volunteers a year, half of them teenagers. The other piece we talk a lot about at Ceres is empowering people. We need to understand that our health is in our hands and not in the hands of our doctor or healthcare provider. That's an important piece, but it's so much about the choices that we make every day. So we want to empower people with their own agency to make a difference for their health, for the health of their children, for the health of their community. We do a lot of amplifying of the movement. So we published a paper called The Power of Our Food Choices about 5 years ago that Barb helped us with. And we do a lot of amplifying and networking across the food as medicine and organic food space to tell stories and to empower people to make a difference. And then finally, advocating. So we are working at the policy level, both locally, statewide, and nationally, which I'll talk about when I get there. So how we do it, just a quick overview. I'm going to start by talking about our community programs, talk a little bit about our national affiliate program, and then I'll talk about the policy and systems change work that we do. So at a community level, we, as I mentioned, we have a client meal delivery and nutrition education program. We serve about 800 families a year across 2 counties, 2,500 square miles. These are all people who are living with a serious or chronic illness. We provide medically tailored meals for everyone in the family. It can range, depending on the programs, from 7 meals a week to 21 meals a week. I want to just say something about serving everyone in the family. There is in most of the food as medicine work that's happening right now, where healthcare providers are paying for food as medicine interventions, it is almost exclusively focused on the patient only. And we feel like this is a serious problem because we know at least 3 things. One is, if you're only cooking for the patient, you're not relieving stress in the family. If you're not only cooking for the patient, it's likely, especially in food insecure families, that patient is going to share that food. And if you're only cooking for the patient, you are not supporting the entire family in adopting better eating habits going forward. And all of those things are really serious problems in achieving the goals that we have for food as medicine. So we serve everyone in the family. We embed nutrition education into our work with clients. So that means starts at intake. We always talk with clients about what they're eating now and about the kind of food that we're going to be providing, which is 100% whole food, organic, the difference between what they've been eating and what we're providing, and why the food that we're providing is important for their health. And then every week when they get their meal delivery, we include what we call a nutrition bite, which is a 1-page sheet that talks about a food or food group that's really important for your health. So it might be about crucifers, or it could be about whole grains, or it could be about a particular food like beets or broccoli. It always includes the kind of high-level benefits of eating that food. There's always a recipe, and that recipe is always in their bag. So it's a really simple way of connecting the dots for them about the food that we're getting. We deliver meals with a team of volunteer delivery angels. We keep the same delivery angel on the same route, so people build a relationship with that person over time, and they're really part of the social connection experience that they have with us. We provide meals for up to 6 months for our clients, and so we've thought a lot over the years about what happens after meal delivery ends and how we support clients in adopting and maintaining those healthy eating habits. We've done a lot of work around this. We had a 2-year grant to test different kinds of transition strategies, and now we have a 2-year implementation grant. Right now, what we offer, we provide a lot of nutrition education classes that our clients are welcome to attend. We also have a cookbook that we sell that is available for clients at a wholesale price. And then once a quarter, we offer a healthy transitions class, which is a 4-hour nutrition education and cooking class on a Saturday. Clients go home from that with 2 prepared meals that they've made, a box of shelf-stable groceries, and a CSA box. And then we deliver 3 more CSA boxes for the next 3 weeks with recipes as a way of supporting clients in moving back into cooking. So our goals are relieve stress and improve quality of life, reduce isolation, help patients feel connected and cared for, prevent or address malnutrition to support healing, educate about healthy eating, and improve eating habits. So this is who we serve. It's primarily women who are over 60 and are poor. And, I always say, if men get sick, women cook for them. If women get sick, they call Ceres. Most of our clients are living alone, and the diagnosis mix is really changing because we are doing a lot more work around congestive heart failure, diabetes, and chronic kidney disease, which I'll talk about in a little bit. So we do a lot of program evaluation. I'm just going to share some highlights with you. We, at intake, we use the FACT-G quality of life survey for cancer patients. We also survey clients on fruit and vegetable consumption and several other things. Our data shows statistically significant improvement from intake to completion of the program on 8 out of 10 of the quality of life measures. So you can see some of them here. Reduction on lack of energy, improvement on social interaction with others, the ability to work, the ability to enjoy life, being able to enjoy the things I usually do for fun, and feeling content with the quality of my life. Now, some of this is obviously that people are also in a healing process over this time, but we're buoyed by the fact that we believe we're contributing to some of these. So 33% of our clients gained weight on the program, and almost 80% reported that their weight moved in a positive direction. And we know that we definitely have clients who come into the program with unhealthy weight. 80% said that they ate more because they had prepared meals. This is especially valuable for cancer patients who often are nauseated and don't feel like eating, but know that they need to. The meals help me feel better. And the healthy meals help me recover more quickly. So these are just, again, high-level results of some of the surveying we do at completion of the program. This is another one. So we look at fruit and vegetable consumption from intake, and then we do a follow-up survey about 4 to 6 months after they've left the program. And we also ask them, since they became on the program, are they eating the same, more or less of these foods? So significantly more vegetables and fruit, and also whole grains, significantly less fast food, processed food, sugar, and also red meat. And then again, some of the statements around healthy eating. So, importantly, 40% said that family members were also eating better, and improvement in feeling confident about making a meal from scratch. 72% changed their eating habits and felt like they had learned something about healthy eating. And again, this is the long-term perspective for us. We want to use the experience of illness in order to not only help people heal and get better, but also to really understand how diet can be an asset for them going forward. So the other half of our equation in our community level direct service work is all of the gardeners and chefs in our program are teenagers between the ages of 14 and about 19. We run two organic gardens in Sonoma County, and 3 commercial kitchen locations, two in Sonoma County and 1 in Marin. On the average shift, there is 1 paid staff, 2 or 3 adult mentors, and anywhere from 8 to 18 teens, depending on the size of the kitchen or garden program. So they come in as volunteer gardeners and chefs. When they join the program, they complete an intake application. They commit to working at least 3 hours a week for 3 months, and about a third of them are involved for 1 to 4 years. So we have kids who join the program at the end of 8th grade or beginning of 9th grade and work all the way through high school. We, along with their, we call embodied learning in the kitchen and garden, where they're basically doing all the work of the program, we also take a half hour each day, and we've developed a curriculum that covers nutrition education, what we call food system education, which includes why organic, why local, composting, hunger and food insecurity, all of those issues, work readiness, and values. And then every 3 months, we have visits with clients across all of our sites for a 2-week period. So the teens get to meet directly with clients that they've been cooking for, really hear their story about what it was like to be diagnosed with a serious illness, hear about the difference that the teen has made in that client's life, and really get to have a conversation. And this is extremely meaningful for the teens, but also for the clients as well. And then we have a leadership pathway. So we are a positive youth development organization, and that's a whole other PowerPoint presentation, but we follow all the best practices around positive youth development. So accountability and holding youth accountable starts from day one. Kids who've been in the program for 6 months earn a green apron with their name embroidered on it. And then youth who've been in the program for a year can apply to be part of our teen leader program. That's a much more rigorous application process. If they're inducted into the teen leader program, they get their own chef codes, and they are really considered part of the peer teachers in the program and role models in the program. And we do every other month leadership development with them. So goals for the youth program: learn to grow, cook, and eat healthy food, understand the impact of your own food choices. And I'll just make an aside. There's some really great research around the fact that among teens, no surprise here, that their own mortality is not necessarily a motivation to improving eating habits, but when you can connect eating habits to social values, so climate, environmental health, social justice for farm workers, those are really big motivators for young people. And we're doing a big kind of revamp of our curriculum right now to do some more connecting the dots around those things. We want to help kids improve their eating habits, access their agency and power to make a difference. And again, I'll say, when I started Ceres 13 years ago, I thought that we were teaching teens how to cook. And we are still absolutely doing that. But what we've recognized is that the most fundamental shift that's happening for this age group is they're moving from locating themselves within their family to locating themselves within their community. And the fundamental question is, how do I find my belonging and value as a contributing member of the community? And that's essentially the really the transformational piece that we support at Ceres. And they all learn how to cook and eat kale. So that happens too. We want them to experience community and understand their power to make a difference for someone else, and understand that they can care about people who they don't even know, and really kind of break their hearts open in terms of their capacity for compassion. We want to increase their self-esteem and self-confidence. Those are fundamental kind of underpinnings for agency, develop their leadership, and help them gain work-ready and job skills. So this is positive youth development stuff, but basically we survey the youth every other year, all the kids that were active in the program, to make sure that we are creating a program that really, where they feel safe, where they feel supported, where they know that the staff cares about them, where they're learning. The second piece, this is just one of many factors on our youth development program evaluation, but we survey the kids on 11 different cooking skills and 4 key gardening skills. The light green shows the number of them who felt extremely confident in that skill at intake, and the dark green is what's added over being in the program for about 6 months. So big improvements on using a knife properly, on steaming and blanching, sauteing, preparing fresh vegetables, and safe food handling practices. So these are some other outcomes during participation. So 54% of the teens at Ceres are eating 6 servings of fruits and vegetables per day, compared to just 20% of teens in California who are eating 5. 77% confident they can prepare a healthy meal from scratch, being able to work with someone who has different opinions, feeling like they've gained responsibility and communication skills, and the importance of community. So we also survey kids every 2 years who've been out of the program for 2 years or longer. And I think these are really extraordinary. So 47% of our alumni are cooking from scratch 4 days a week. I often ask rooms full of adults, how many of you are doing that? And there's not that many that raise their hand. 78% still say their diet consists of mostly fresh whole foods. 60% continue to be involved in the community. 58% are working or studying in fields related to our work. And we define that as nutrition, public health, medicine, or nursing, obviously within that, sustainable agriculture, culinary, and community organizing. And more than 3/4 say that their time at Ceres was a key influence. So we also do a significant amount of nutrition education. Last year, 99 classes in the community. We are the primary nutrition provider for 2 community health centers. We also are now working with we've been working with the Sonoma County Public Library System for about 4 years. Now we've added Marin. We did about 30 classes at the libraries last year, including 23 classes for kids, including, I think, 5 to 8-year-olds, and then a separate 9 to 12-year-old series. All of family stay. And of course, the people who use the libraries tend to be some of our more low-income people in the community, which is really important. At one of the community health centers, we do half our classes in Spanish, so lots of bilingual outreach as well. And then we do our own series of classes. I mentioned the Healthy Transitions program. We have also been developing a cohort-based program that is aimed at people who have medical risk factors for cardiovascular disease. So that's either hypertension and or diabetes. It's a whole family program. The first time we did 12 weeks. Now we're looking at an 8-week program, and it includes nutrition education and food access. And we're now applying for funding under USDA to move that into a produce prescription model, which I think is going to be really important. So lots of more prevention-oriented work that we do in the community that really builds off the work that we do in our core program. So the next thing I'm going to talk about is our affiliate program. So this is a program that we started back in 2010. So we were 3 years old. We had published a cookbook in 2009. I'm not getting a slide. Let's see what happens. There we go. Nope. This is skipping forward. So let me go back here. Okay. So there we are. So in 2009, we got a call from a program in Bay Village, Ohio, who had learned about what we were doing, and they were really inspired and wanted us to help them bring it to their community. And we did that for about 3 years. And you'll see at the bottom, St. Helena, California, Bay Village, Ohio, Summit, New Jersey, Charleston, South Carolina. Those are all programs that we worked with in our early years before we had developed our whole affiliate program. And then in 2012, 2013, we developed a licensing model for our affiliate program, a full 4-day training, an operations manual, and now basically we bring people into that affiliate program who are interested in learning about our model and bringing it to their community, and we support that group of organizations through kind of a backbone support as a learning collaborative. So we do an annual 2-day retreat for all of our affiliates. We have monthly calls that cover kind of the 4 core parts of the program. And then I support the executive directors every other month with a 90-minute call where we work together on operational and other issues in running their program. So this is a way that we have been able to figure out to really scale this work at a pretty low cost structure in a way that makes it really affordable for these communities to work with us and to learn from us, and as I always say, not repeat our mistakes. So finally, I'm going to talk about the policy change work. So we are focused on 3 different areas in the policy space: conducting research and high-level research to prove the case about food as medicine, working to integrate food as a covered healthcare intervention, and then within the food as medicine landscape, really promoting the importance of organic and sustainable food systems. So I always have this slide in here. It's really, these are not going to be numbers that are new to any of you, but I think it's really important that we ground ourselves in the reality around this, which is 42 million Americans are nutrition insecure. That is linked directly to 77 billion in healthcare costs. 60% of deaths now, 1.5 million people annually in the US, are tied to poor diets. Poor diets are the #1 cause of mortality, according to the CDC. 40% of children with pesticide levels that could impact brain development. And we know that conventional agriculture is a leading cause of climate disruption, but organic regenerative systems could be a part of the solution. And I just think that we can't get away from the extent to which our food system and our eating habits are contributing to the epidemic of chronic disease. We know that 1 in 3 people enter the hospital malnourished. Among older adults, and this is slightly out of date, among older adults, 92% have at least one chronic illness and 77% 2 or more. We know that those numbers, the aging of the population is going to really impact that. And 86% of healthcare spending is attributed to people with chronic health conditions. So these are undeniable. Finally, again, most of you, I'm sure, are aware of the social determinants of health work. The way that I talk about this is, 30% of our healthcare is only 20% of our healthcare is what's happening in the doctor's office. 30% are the choices that we make every day: tobacco, diet, smoking, tobacco, diet, good sleep, friends, all of those things. But critically, 40% of our healthcare is related to the things that are out of our control. So lack of education, poor job, not making enough money, food insecurity, all of those social determinants of health. And I'll just say there is a just incredible momentum happening around food as medicine right now. And it's because our healthcare partners and providers are recognizing that they are not going to be able to solve the epidemic of chronic disease without going outside of the doctor's office and without addressing some of these social needs. So these are 2 slides from Rita Nguyen, who's at the San Francisco Department of Public Health. This slide is really around just food security interventions and the impact on health. So reducing hemoglobin A1C, reducing blood pressure, BMI, preterm birth, and depression, and increasing medication adherence and heart failure and symptom control. And those studies are on this slide. And then here's a couple of other ones around the benefit of SNAP for older Americans, and also the long-term impact of children who have had SNAP in their childhood compared to those who haven't. So those are simply food security, not medically tailored nutrition, which is what I'm going to talk more about. So again, we know that there is a whole spectrum of food interventions that we need to be bringing to the table. And this is just one way of looking at the kind of intervention we look at relative to where someone is on the prevention treatment continuum. So going from SNAP and school lunch, food banks, food pantry programs, veggie prescription programs, to medically tailored groceries and medically tailored meals, which I'm going to talk more extensively about. So medically tailored meals are meals that are designed by a registered dietitian as an appropriate part of a treatment plan for an individual with defined health condition or a combination of health conditions. The registered dietitian assesses the client need and ensures that the medically tailored meals provided are appropriate and supportive, and they collaborate with kitchen staff to ensure that meal preparation and packaging adhere to nutrition guidelines. Medically tailored meals were developed by Food as Medicine organization that started with the AIDS HIV epidemic back in the late 80s and early 90s. And there is a coalition of organizations around the country that are now make up the Food as Medicine Coalition and the California Food as Medicine Coalition. What they learned really early on is when AIDS HIV patients had good nutrition, they were able to control their viral loads and not pass on the disease. Because of that, the federal government included home delivered meals as a covered benefit within the Ryan White Act in 1990. And there continues to be a federal funding stream for medically tailored meals for AIDS HIV patients. Since then, those organizations expanded their missions. Many of them now serve people with lots of different illnesses. And it is the Food as Medicine Coalition that has really set the standard for medically tailored meals and has done most of the research for medically tailored meals over the last 10 years. What we know from those published studies so far is overall, when medically tailored meals are provided to a wide range of patients with different illnesses, we see somewhere around a 16 to 20% net savings on the healthcare cost side. People are 23% more likely to be discharged to home. There's a big increase in medication adherence, a significant reduction in hospitalization, and all of those are being shown kind of consistently across a range of peer-reviewed and published studies now. So I want to talk a little bit about the state of the field and who's playing in that space. And I'm going to start with the statewide medically tailored nutrition pilot that we're doing here in California. So I started a conversation with our state senator at the end of 2016. And he came back to me and said, why don't we see if we can get California to fund the first in the country statewide medical nutrition intervention in our Medi-Cal system, which is our version of Medicaid. I was able to put together a coalition of organizations you'll see in the green in San Diego County, LA County, Santa Clara, San Francisco, and Alameda, Marin and Sonoma, which is Ceres territory. And we were successfully able to lobby the California legislature in funding a 3-year study in 2017 with a $6 million investment. It took about a year to get the contract worked out with Department of Healthcare Services. We're about halfway through that study right now. We're actually going to extend it for another year. And we are, we will be providing 1,000, it's probably going to be closer to 1,300 Medi-Cal patients who have congestive heart failure with 3 months of complete nutrition plus 3 home visits with a registered dietitian. And our goal is to show healthcare cost savings within the Medi-Cal system in California. Just want to check to see. So it's all meals for 12 weeks, medically tailored for CHF. We do wellness checks at each delivery and RDN visits. Before I go to this slide, I just want to say we are tracking data for these patients. This is not data in the Medi-Cal claims database. There'll be a whole evaluation of this intervention that will happen once the pilot is complete. But the statewide 30-day readmission for this population in California is about 32.5%. And our 30-day readmission rate for the population that we've served so far is under 6%. So it's, that's not data that we're writing down, but I will just to say we are showing dramatically decreased readmission rates for this population with the medical nutrition intervention that we're doing. And I'll talk a little bit about some of these other things that are happening as a result. So because of the work that we've been doing in California, Department of Healthcare Services here is now doing a whole revision of the Medicaid system in California, and they have included home delivered meals at discharge from the hospital and medically tailored meals for about 8 different diagnoses as an allowable, what's called in lieu of service benefit. So these are benefits that the plans can offer. And the belief is, for example, our belief is if we provide 8 weeks of meals to you at discharge, it will be in lieu of paying for a readmission to the hospital. So that's why they're called in lieu of service benefits. This is it's the first time a state has written meals into its Medi-Cal system in this structural way that California has done. So it's really significant. The waiver application will go to the federal government in July, and we are now working in California to lobby the plans to offer that benefit. So now it's really up to the plans. It will be structurally available in California, and now we're working to make sure that the Medicaid plans write it into their contracts with DHCS and offer that benefit. Medicare Advantage, some of you may know this already, but Medicare Advantage has already changed and made medically tailored meals an allowable covered benefit at the federal level. That happened a year ago. And again, now it's up to the Medicare Advantage plans to offer that benefit. We are working on a project with Kaiser, which I'll mention in a minute. And it looks like they will be offering medically tailored meals to their Medicare Advantage patients starting in 2021. We are also working at a federal level with Congressman McGovern's office. He is a congressman from Massachusetts, and he is working on introducing bipartisan legislation to do a 10-state medically tailored meal pilot in the Medicare fee-for-service system. And we're hoping that will move forward in the next little while. And then I will basically say that almost every major insurer in the country has at least their toe in the water around food as medicine intervention. So in California, we're doing pilots with Anthem and Blue Shield Promise. We are getting ready to do a significant large-scale randomized control trial with Kaiser. Humana is doing a significant amount of work in this area in the Southeast. And I could go on and on. There's really a lot of momentum happening in the space. So here's some of the challenges. We need to get the plans to offer these benefits. It's great that they're available, but we need every Medicare Advantage plan in the country and every Medicaid plan in California to be offering these benefits. We really have to find champions within plans and provider organizations to make sure that this work moves forward. There's a lot of work to be done around integrating referral of these services within healthcare organizations. And I'm sure a lot of you are familiar with this, but who is the person who identifies and refers patients? We need community health workers, patient navigators to be really leading on this and integrated in. How is it paid for? Where does it live in the electronic health record? And how do we develop the billing codes? A lot of this work is happening, but there's a lot of work to be done. And then the whole issue around how clinical partners refer to non-clinical partners. What are the referral platforms for that? There's a lot of work happening around bidirectional referral platforms, developing business associate agreements between clinical and non-clinical partners. How are we dealing with HIPAA compliance issues? There's just a lot of logistics here that we're all really wrestling with. And we're doing that work here in Sonoma County. We have a clinical community collaboration around cardiovascular disease, where we're working on some of this at a community level. There's also a statewide effort in California to get guidance from California's Health Information Integrity Office around HIPAA between clinical and non-clinical partners. And there's a lot of work I know happening at a national level. UCSF is doing a lot of work around developing the ICD-10 and billing codes for some of this. So, lots of momentum, but no shortage of challenges as well. I'll just end by saying, if you are interested in the organic side of this work, The Power of Our Food Choices is a report that Ceres did 4 years ago that really looks at a lot of the research around organic versus conventional food systems and their health impacts. I would also direct you to California Certified Organic Farmers, who in 2019 produced their benefits report. It's looking at 331 studies on the broad spectrum benefits of growing organic in California, looking at economic prosperity, social justice, and climate environment. Really, really good resource. And again, Root Cause Coalition is an amazing national organization that is bringing together providers, healthcare providers, insurers, and nonprofit organizations around the integration of social determinants of health. So I'm going to stop there. That was a lot. And I have another 10 or 12 minutes to field questions.
Cathryn, that was brilliant, as always. Thank you. And I'm going to ask that our participants write their questions in the chat box. And I believe there may be one already. So this is coming from Peggy Slota. She says that she sees that the meals are packed in plastic. Have you considered using the foldable cardboard containers? And I know you have addressed this, but if you could tell the audience about that, that'd be great.
Well, if you talk to anyone in the food space, you will hear that packaging is a huge, huge, huge challenge. And there is no good solution. For years, we have used reusable food grade plastic containers that we picked up every week, sterilized and reused. We are trying now to move to single-use containers that are actually better for our clients, easier for our clients to use. But all of them have lines that we don't want. And even though they say they're compostable, it is very difficult to compost things. We can't, because we are our clients need to, we are making food. We have people that are delivering that food in bags with multiple containers. That food has to last for a period of time and be able to be reheated. Plain cardboard containers will not work. They're not sturdy enough. And we have just heard from one of our packaging suppliers that they are coming out with something without the lining that we don't want. So we're optimistic that this is getting better, and we're working. So Organic Sustainable Community, OSC2, that you see on here, is a collaboration of large organic food companies that are doing a lot of work around packaging and food waste. But there's no good solution right now, and I'll recognize that we're not happy with what we're doing, and we're trying our best to make it better.
Thanks. Very complicated. So you get a bravo, amazing, from one of the other audience members, and she's interested in knowing who they can contact if they have an interest in growing a project and becoming one of the affiliates in their local area. What is the best way to enter that conversation?
If you just email us at info@Ceres, CERES project.org, it will get to Nadine, who's our national affiliate coordinator. If you go on our website, which is ceresproject.org, under affiliates, there is a downloadable PDF that is like a 30-page kind of overview of how the affiliate program works. But if you email info@ceresproject.org, Nadine will reach out to you and talk with you about the process.
Excellent. Good. And so from your perspective, Cathryn, how do you see this moving forward now? How optimistic are you that we're going to be really seeing some significant shifts, say, in the next 3 to 5 years?
I'm actually extremely optimistic. Medicare has made this change nationally. We also do a lot of work with the Center for Health Law and Policy Innovation at Harvard, which is an amazing team if you're not familiar with them. And they are doing a lot of the policy work nationally. We have tried to get the Center for Medicaid Services to agree that the existing Medicaid language actually would allow for food, and they've said no. And so the Medicaid work is really happening at the state level. But there's great work that's happening in North Carolina and Colorado. Massachusetts, if you're not familiar, has developed a Food as Medicine state action plan and are really working on legislation to address food as medicine at a statewide level. Now, Massachusetts is, of course, not nearly the size of California, so it's easier to do that in a smaller state. But it's amazing what California is doing right now. So if we can move this initiative forward in California and really begin to integrate food as a reimbursable medical expense across California's Medicaid system, at the same time, and again, this is some confidential, but Kaiser is making a huge commitment to developing a national food access strategy called Food for Life. And within that, will by the end of this year have conducted 4 large-scale randomized controlled trials on medically tailored meals, and are looking seriously at how to integrate medically tailored meals into their business model. And they are committed next year to going out and doing and getting the research published that they have conducted, and also presenting nationally on it. So I think the combination of what's happening in Medicare, the number of insurers who've entered this space and are doing their own kind of trials and pilots, the work that's happening in California and the work that's happening at the level of someone like Kaiser, I firmly believe that in 5 years it's going to look completely different, and in 10 years we will have really made a shift. And again, I think that it really comes from looking at the data and understanding that we are not going to get costs under control, and we are not going to get quality improvement around things like diabetes and hypertension without addressing some of these upstream things. And I think that's become obvious to insurers, and that's really what's driving the change.
Excellent. And I have another question, which is, How well is the intentionality of organic foods being integrated into the conversations and the policies? And I know it's been very important to you, but now that this is being scaled and bumped up into something at a much higher level, are we going to be able to keep, or are we going to lose some of that?
So I think this is really critical. And this was the aha that I had a year and a half ago, which is there is all of this momentum around food as medicine. And the danger is, and especially not so much in the food security or veggie prescription space, but in the medically tailored meal space, there are some large for-profit entities that are really going after the healthcare dollars, and they are low-cost providers with no food security guidelines, no food quality guidelines. And as all of these dollars are coming available from our healthcare organizations, this is the moment to start to make sure that those dollars are going into the right things. So I would just say, I think it behooves all of us to bring this up. So in conversations that I was in with Kaiser nationally last year, I said to them directly, you need to not be using this company as your medically tailored meal provider. If we are not investing these dollars in locally based organizations that are sourcing locally, that are sourcing organic, we are missing the opportunity to build health and resilience at the community level, and to connect the dots between these things. So in the work that we're doing with Department of Healthcare Services in California, we are asking them to make locally based organizations the preferred provider for those services, and to give preference to organizations that are sourcing locally and sourcing organically. With Kaiser, with the research study we're doing with Kaiser right now, they are paying us extra because we're doing organic. That's a huge step in the right direction. But I would say we have to be raising conversation at every table that we're at, because the danger is if we don't, we are going to miss the opportunity of the moment. And that is really significant from my perspective. So we are working locally at, I'm working with my colleagues in the California Food as Medicine Coalition to establish food quality standards. We're working with DHCS to establish food quality standards. We're working with Kaiser to do that. And I think all of us have to be doing that wherever we're at the table, and not settling. And really doing education, I think, to have people understand why it matters.
Cathryn, this has been absolutely exciting for everybody, and I can see via the questions and the kudos in the responses of the audience. And I'm just afraid that we're just about out of time. But what I'd like to ask, I think that we will bring this up at our next committee call to see whether there is both interest and perhaps a way that we can more visibly support the notion that as we move forward towards medically tailored meals, that we think about them more comprehensively and think about the quality of the food and the companies that are going to be offering these foods. So thank you for raising that as the many issues that we need to be tracking. And again, just thank you for taking, I know how busy you are. Thank you so much for taking the time. This will be archived. Many more nurses will be watching it. I know that I'm going to use this lecture in my classes. So once again, just thank you.
Yeah, thank you guys for having me. And I just want to say that I'm really happy, Barb, as you know, to be a resource to ANHE around kind of what's happening. Food as medicine. I've just been asked to join a advisory board at the Aspen Institute's Food as Medicine program around developing a national research action plan for food as medicine. So I'm connected into some of the work that's happening nationally, and I'm happy to be a resource to all of you.
Terrific. Wonderful. Thank you. Thank you.
All right. Thank you, guys.
And as we begin to come to the 1 o'clock, at least on West Coast time, I just want to remind everybody, you'll be getting an email reminder from ANHE that our next call, when we'll have an opportunity to talk amongst ourselves about this and some of the other issues, will be April 6th at noon Pacific time. I let you all figure out what time that is for you. Please mark that in your calendars. And thank you once again. Thank you so much for joining us on this webinar. Take care all. Bye-bye now.